All right, well, welcome back to Chapter 17 of your Psych 121 course. Let's talk mood disorders for a bit. Now, just by way of beginning, it's always important to note that, in a lecture, and especially in a video that's going to be 20 minutes or less, you are not going to get all the nuances of each disorder, right? Like, that's just not possible for us to do. And so, what I'm trying to do is give you really big picture kind of thinking here about these particular disorders. So, what are we talking about when we talk about mood disorders? Well, mood are affective disorders. They impact our affect, our expression. So, when we're talking about mood, we're talking about the positive or negative feelings that are in our everyday lives. Mood, as we've talked about in previous sessions, it affects our behavior and our thinking. So, when we're talking about mood or affective disorders, we're talking about psychological disorders in which the person's mood negatively influences their physical, perceptual, social, and cognitive processes. So, people who suffer from mood disorders tend to experience more intense, and in particular, more intensely negative moods. So, the most common symptom is negative mood. So, for example, in depression, we would look for sadness. About 5% of Canadians suffer from a mood disorder each year. Now, it's important to note that mood disorders can occur at any age. While the median onset is around 32 years, this is by no means the only time where mood disorders can be prevalent. Now, about twice as many women as men suffer from depression. And this gender difference appears to be consistent across many countries and can't be explained entirely by the fact that women are more likely to seek treatment for their depression. Now, a little bit later on here, I'm going to give you a possible solution to this problem, but stay tuned. Now, when we're talking about mood disorders, we generally are talking about depression, and we're talking about bipolar disorder. So the first we'll talk about is major depressive disorder, or what we commonly call depression, or clinical depression. And this is a mental disorder that's characterized by low mood, low self-esteem, and a loss of interest or pleasure in things that a person normally that they used to enjoy. So every year, about 4.8% of Canadian adults suffer from major depressive disorder. And the rates of depression have been increasing. So that is kind of one, and we'll talk a little bit more about some of the kind of characteristics, but in addition to this, there is another type of mood disorder in the depression kind of category called dysthymia, and it's now known as persistent depressive disorder, and it's characterized by somewhat milder but chronic depressive symptoms that have lasted for at least 2 years. Now, the onset may initially have been due to a major depressive episode or major depressive episodes that have occurred at anywhere kind of within that 2-year time frame. Now, most people with PDD describe themselves as always having been this way because their depressive symptoms have been just so long-standing. So when we're talking about depression, we're talking about feeling sad, empty, or hopeless, having a loss of pleasure or interest in most daily activities, having changes in appetite, either weight loss or weight gain, having difficulty concentrating, remembering details, making decisions, fatigue, decreased energy, feelings of hopelessness, helplessness, pessimism, increased use of alcohol or drugs, irritability and restlessness, impairment to sleep, so either insomnia, so not sleeping as much as you should, or hypersomnia, sleeping for a much longer time than you should, or than what normally would be necessary. There are many different ways for depression to kind of express itself. A loss of interest in activities or hobbies that were once pleasurable, including sex, loss of interest in personal appearance, persistent aches or pains, headaches, cramps, digestive problems. There we go, the sleep disorder stuff. See, I was getting ahead of myself. And then thoughts of suicide or attempts at suicide. In men, anger as well is can be a very important diagnostic feature. Now, with major depression and with dysthymia, we're talking about just feeling very low. There's another mood disorder called bipolar disorder, and this is one which it's characterized by swings in mood from overly high to very sad and hopeless and back again, with periods of near normal mood in between. Now, it's commonly been believed that Vincent van Gogh suffered from bipolar disorder, And there's some interesting kind of art historian kind of profiling that they've kind of done about him. But really, for bipolar disorder, it's a very challenging disorder because it's chronic and it's lifelong, and it often begins in childhood. And this is one of the things that makes it so darn tough, because there is a lot of research now demonstrating pediatric bipolar disorder is a thing. And so, but I mean, at the same time, as a clinician, it is a hard sell for me to think I'm of diagnosing a young child, 8, 9, 10, with bipolar disorder, because we know of the chronic and lifelong condition that it is, and especially if you're getting it wrong. I mean, that's kind of, I guess, probably a large part of the fear from a clinical perspective. Now, sometimes a person may experience these highs and lows, these incredible mood swings simultaneously. Um, the other thing, though, is very challenging is bipolar disorder is often misdiagnosed, because it's difficult to really get to a clear picture of bipolar due to the high comorbidity it has between depression and other anxiety disorders, as well as the fact that unless you're doing a good job of assessing for that mania, the kind of the upswing in mood, you can really kind of miss it. So this is a chart that I think is kind of helpful to talk a little bit about depression and talk about the range of mood. All right, so in the middle here we've got euthymia. Okay, so that's just kind of flat, normal. Okay, and then you go from there into happy and from sad. Okay, if we look at something like major depressive disorder, okay, you can have the whole range here from euthymia, just that kind of middle point, all the way down to depression and suicide or even psychosis. Okay. With depression, you're never getting to happy, right? But you're just always kind of in this range of like flat all the way down to very, very low. With dysthymia, it's generally, like I said, considered a somewhat milder version of depression, but again, never really being happy and still being in this depressive range. Cyclothymia, which is kind of within the bipolar family of disorders, this is where you are kind of seeing a range here of kind of mild depression to elation or hypomania, but never quite hitting that mania kind of point. Same with bipolar. And then look at bipolar 1, right? I mean, you've got the whole range of emotions all the way here from depression and suicide and or psychosis on this end, all the way up to mania and psychosis on this end. So it's important for me just to maybe clarify here. So when we're using the term mania, what we're talking about are these times of really just an amazing amount of energy. All right, so this is the time where you can get stuff done. You can, and not just get stuff done, but you are in this state where you are energized. You don't need as much sleep. Your mind is racing. You're making decisions that are not always very good decisions. I mean, a dear friend of mine suffers from bipolar disorder. And I mean, for him, he completed his entire PhD dissertation in the period of about a month due to a manic episode. All right. And so for him, I mean, he was not sleeping, he was not eating, he was just writing his dissertation. And when he finished that, like when that period, that manic period ended for him, he crashed, and he crashed hard for several months. So we're talking here about, and I mean, here's the thing, is you're losing function at both ends of that extreme, right? So that makes it a very, very, very challenging disorder to experience. Now, here's kind of, I guess, my little interesting aside about gender and depression, okay? So in 2012, 5.8% of females reported depression in the previous 12 months, compared to 3.6% of males. But in the same period, 4.7% of males met the criteria for substance use disorder versus 1.7% of females. This kind of finding has led to this idea that perhaps the way that men respond to depressive symptoms is self-medicating through alcohol and drug use. All right, so the findings are inconclusive. We haven't really nailed this down, but anecdotally, as well as based on some of the data that we can kind of pull, it seems to be that this might actually be a thing. And so that might explain some of the gap between, in depression and gender. Now, how do we explain mood disorders? Well, we know that at least in part they are genetic. We know that there's a heritable component to most of them. We know that neurotransmitters play an important role in mood disorders. And we do know that the brains of those with mood disorders may show some structural differences from those without them. Again, these differences, and it's not always super conclusive, but I mean it looks like there might be some differences. But we also know at the same time that their psychological and social determinants play a significant role in mood disorders. All right. So for example, mood states are influenced by our cognitions. So for example, negative thoughts create more negative moods. Um, and this has kind of led to some of the theorizing. So for example, Aaron T. Beck, who actually just recently passed away at the age of 100, is the father of cognitive behavioral therapy. And so he came up with an interesting conceptualization of depression, which we now know as the cognitive triad. And so Beck said that people who are depressed have automatic thoughts, have cognitive distortions that are negative, highly negative, and they tend to be very strong negative views about themselves, about the world, and about their future. All right, and so he talked about the role of automatic thoughts in maintaining depressive symptoms. So, so I guess Beck's information kind of gives us a little bit of a larger picture that even though there might be this genetic factor and these genetic components to it, there is also a strong social cultural component, and as well as a very like an individual psychological factor of the fact that these thoughts can actually maintain things. So, there was some talk earlier in the chat earlier in the semester about so how do we help people with depression? Should we just teach them to think happy thoughts, right? Well, no, that in and of itself, that won't necessarily change things for them. But what we can do is we can begin to help someone to alter their thoughts a bit, which can in fact can shift things. But I'm getting ahead of myself. That's next week, so hang in there for that, and we'll talk about how do we actually then combat depression. How do we fight against it? So back to explaining mood disorders. Now, we know that rates of depression vary greatly among countries as well. Rates of depression are highest in European and in North American countries, and lowest in Asian countries. Now, here's where we kind of see again the role of culture. Culture, folks, is so important in understanding what is and is not mental disorder. These differences might be due to discrepancies between individual feelings and the cultural expectations of about what you should feel. So it leaves room for us then to consider whether different ways of conceptualizing what we feel might actually be helpful to address mood disorders. Curious to know what you think. Throw some information in the chat about what you kind of think about all of this stuff. Look forward to hearing from you, and we'll talk about schizophrenia next time.